Well, hello, everyone. Nice to see you all again. Sorry for not eventually having immediate recordings. Having a baby in the next 3 months make you so busy when it comes to schedules and all of that. But nonetheless, I will keep flooding you guys with everything that you need in your preparation, as well as that of not just questions but tools as we progress in this very nice learning relationship that we all have. So again, it's me, Coach Alan Giliacola. Thank you for joining me again for another session of these 30 to 40 minutes of learning session intended for the purpose of preparing you for your international exam, whether it be NCLEX, HAAD, Prometric, UKCBT, even OSCE. I'll be more than happy to help you. So wherever you are at the moment, United States, Philippines, Nepal, Australia, African region, and for every nurses in the Middle East region at the moment, rest assured we are praying for your safety. We are praying for the most peaceful resolution for whatever conflict is happening there. At the end of the day, regardless of whatever ideology, religion, policy that you might go with, we will all agree it's better to live in peace than in constant threat of possible death due to war and any form of violent escalations. So if there would be nurses that are listening right now in the area of Saudi Arabia, Iran, um, Israel, those Middle Eastern regions, Qatar, was just recently attacked as well. Our prayers for your safety, as well as that for every peaceful resolution of whatever is happening there. Okay, so of course we're here for the learning session, and it wouldn't stop us simply because everything is still in motion. Everything is still going to happen. There will still be nurses who are about to take their exams in the next few days, and there would also be nurses that I still needed in order for us to run the healthcare system wherever you are in the world. Regardless of what's happening, people will get sick and we will all be needed. So, without further ado, let's begin our discussion when it comes to today's focus. So, this is now full NGN format questions. I want to point out three things before we move forward into the questions because I receive a comment. Most of you who knows me must have seen my post or following my main page must have seen my post about someone being rude, messaging and commenting on our group. So that comment was intended to do three things: question what I am doing, indicating that I may not be able to know what I'm doing. And the last one is questioning the legitimacy of what I am teaching. Okay, I just want to address it one thing, especially for those who are new here. Again, this is a free initiative, no payment, not a penny, not a dime, nothing. I am not requiring anyone to pay in order for you to access the learning materials that I'm developing here. This has been my advocacy for 12 years, since 2013. Why? Because during those times, a student of mine from the Philippines asked me if they could be able to get a review and a preparation support as they're about to take NCLEX as well as that of HAAD. During the time, international reviews in the Philippines could cost you at least 25 to 30,000 pesos. Roughly, let's just say 400 to $500 US dollars. And these nurses who would want to have the chance at this exam are only earning $200 a month. Yes, that's the reality of nursing where we came from. Underpaid, underappreciated. So, how can they have a preparation when you need to shell out $400? Twice the amount of your monthly salary in order for you to prepare. I'm not even counting the papers, the credentialing aspect of taking those examinations. It would also entail money. In fact, if you're going to look at it, if you're going to add reviews into the mix, more likely you will see at least a $500 value in preparing for your NCLEX. Same goes when it comes to your Ha'ad if you're going to go to the United Arab Emirates. And that is the one that triggered this initiative. Okay. It's for every nurses who would want to have the equal access as well as that of a preparation that they need in order for them to face this international exams. I am not pertaining to any organization or to any learning organization. Do your thing, I do mine. Mine is this is for every mom and dad nurses who are literally making end or rather making ends meet and making sure that night and day meets in order for them to study and at the same time take care of their family. This would be for that student nurse who don't have a permanent job in order to support him in his or her preparation for the exam. This is intended for nurses who are out of our profession, those who have gone into another profession simply because they are not paid enough and would want to still get back to their nursing dreams. This is what this initiative is for. Not for me, not for my own self. To be honest, I am being paid well with my job and I couldn't ask for more. Thing is, there are nurses there that needs our help. And that's why we built this community. I built this community. Second point is that if you're questioning my, let's just say, credibility, it's always being questioned. Everyone, especially for those who would feel threatened because they are running business, and of course, peer review is a threat for them, would question my credibility. I already placed my intro video there, guys. It's up to you to believe in me and to accept the learnings that you will have here. Okay, this is again free learning. If you see that my videos are helpful, please share and please tag your friends in order for them to see the same and to learn the same. Nothing more, nothing less. Go ahead. Why? Because again, this is for every nurses in order for them to have an equal opportunity. And if there is still a question if I am qualified to teach, well, everyone is. Hell, we have influencers who just discovered YouTube, started some pranks, and people are literally flocking on them. How much more free education, right? So this has a purpose. This is not just something, and this has been going for a long time. And probably the last point, why am I not starting with a full discussion or free learning? Because I want to introduce NCLEX. Okay, I don't want to start preaching the entire nursing discipline when the fact of the matter is it is the exam that is literally challenging altogether. A mentor of mine, way back when I was starting in the review as well as that of the nursing education industry, as well as that of the academe, always told me there will always be changes in nursing. So you need to continue learning. Okay. What does that mean? Everything that I am placing out here is not for the purpose of saying that I am the best. It is for the purpose of making sure everyone learns. And how it would be best to learn? To know first the exam that you're about to take. Because if you are an internationally educated exam, this is not an exam that you usually see in your regular nursing finals or midterms or whatever exam that you have taken. That's why you need to have a deeper understanding. Why do we need to build up analysis skill? Why do we need to be aware of the difficulty of how it actually progresses? Why do we need to make sure that we are ready of whatever nursing concept is in front of us? It's because that's how NCLEX is. It doesn't have a pattern. It could throw a random question at you, and the second question is not even related with the first one, and still it will grade you. And that's one of the most important thing. I have been blessed to be given a glimpse of how the clinical judgment measurement model came into fruition from the first time that I was able to be on an NCLEX conference, which I'm proud to say that I was also extended an invite again this year, and that will be in September. That is only 3,000 seats, so I'm lucky to have received the invitation. So that's a good one. But nonetheless, I've seen how this exam changed. And it would be a disservice for me personally as an instructor as well as an educator if I could not share that knowledge, especially for those who are about to take it. Much like what they say, as cliche as it is, anyone who goes out in a war without a plan will always lose. Failure to plan means planning to fail. And in order for you to make that effective study plan, you need to know what you're about to take. What battles would NCLEX throw at you in order for you to actually answer it effectively? So, yes, I hope that buries everything. There would be thoughts. Again, I'm open to criticism. If you want to give your suggestions and comments as an educator, I would always listen because it's necessary. And speaking of that, in terms of listening, yes, I'm listening to you guys. People have been messaging me. Sir, could we also have concept contents, especially in pharmacology, cardiology, neurology, psychiatric nursing? Yes, as cliche as it is, again, your wish is my command. I will start doing lectures focusing on those, and as well as that of handouts that you could download from the group in the files tab. So feel free to browse that files tab. I will fill it this week with all the rich concepts, PDFs, files, whatever it is that you need. And then I would also add more videos in this group focusing on the concepts that most would probably be having a problem. Another bonus that I will be giving you guys is I am already preparing a free 25 to 30 items exam that you could practice on your own on an actual online testing delivery system that I myself is part of. So I will place the link here. Watch out in our group, and I will be able to place the link there. Final message as well for those who would want to have, because there's also a clamor that for me to have an actual private class. I'll try, okay? I'll try to put one simply because my wife is near her due date. So I don't want to commit to start something like a full class and then leave you hanging in the middle of it because I needed to focus on my family. So I'll try my best to fill the group, how to fill this group with all the information that you need, from concept to test taking drills to files that you could use to links wherein you could get free questions and practice in order for you to maximize your review. Okay, so let me just share that screen again. Mhm. Okay, So if you have noticed, I am already using Google Meet in order for us to have an interactive discussion. The reason of which is this would allow me to render, okay, render everything quickly, especially when it comes to um, the materials that we are about to use. So if you're going to notice, most of the structure of the videos are essentially the same as to what you are saying. Okay, what you are seeing in the recording altogether. So hopefully, it would not bother you, and hopefully, it will also not be a hindrance to your learning. So, this is now our NGN format and standalone questions. So, one thing that I would want to emphasize with everyone when you're dealing with standalone questions, they are also in NGN format. However, they are not totally focused, okay, on a case presentation. As it says, they are standalone. So, how do we make sure that we are doing it great? Okay. Oh, I forgot, by the way, before anything else, um, thank you. Thank you for everyone who have joined in the group at the moment. I think, let me just double check the Facebook page here just to make sure that I am um, seeing it correctly. Oh, yes. Thank you very much for all 400 new people who have joined in this group. Thank you. Thank you for trusting me in my initiative, for trusting the learnings that you are getting here. So, again, for everyone who's here, share the word, okay? Share the word. There is a preparation that you could use for free. There's a community that is emphasizing and championing free learning, especially for nurses. So spread the word out there. Okay, let's share the blessings. Each and every one of us are nurses, and who else could help us but also other nurses? So let's make it happen for everyone. Okay, so let's begin with our number one. Okay, the first question that we have here is about hypoglycemia. One thing that I have also wanted to emphasize and focus on this discussion now is that if you have noticed, the questions or the stem itself actually indicates four items that needed to be prioritized. Now, this form of SATA, whereas there is a targeted number of responses, is actually something that would give you a hint of how it is being scored. Okay, right now, there is what you call a positive negative scoring in NCLEX. So, what is this positive negative scoring, sir? What does this entail for everyone who's about to take NCLEX? Okay, the positive to negative, okay, the positive to negative um, uh, scoring model is when there is, putting it simply, right minus wrong. If you are going to notice, there is an actual, okay, requirement of four choices here that you needed to find in the question. So, sir, what if I chose five? Okay, the extra one would be counted against the overall score. Okay, what if I choose four and one of them is incorrect? And then it is again right minus wrong. So if you got 3 out of 4, okay, the score for you for this one is 3. And then based on the actual logit, okay, logit statistics, it will be evaluated based on the level of the capacity and the difficulty that the question is presenting. So, yes, apart from the fact that there is a progressive scoring in NCLEX at the moment, wherein the more that you answer correctly in succession, the more is the chance of you passing, there are also applied Okay, applied ways of how they are going to correct this type of question. That's the reason it's imperative for you to analyze the question effectively in order for you to get the most correct answer, especially if you have something like this. So, guys, I'm not sure if, because I'm seeing my video sometimes freeze, we are having some problematic internet connection for the past few days because of the heavy winds here in Albuquerque, where I'm located at the moment. So again, I'm very sorry if there would be a hang, but hopefully you could hear me and it's not cutting off the actual communication that I have. So another question, or rather another scoring, is the actually 0 1 model. Let me just erase all of this here. Okay. So what is the 0 1 model scoring? So the 0 1 model scoring is something that is focused primarily on the actual, okay, the actual correct answers. So if you will see a SATA, okay, a select all that apply, that doesn't have a specific number to it, then essentially you will be scored for every correct answer that you will get. So let's say, for example, there would be a matrix question, something that I have prepared for you as well on one of this, and there are like three. If you got all the three, you will be scored three. Okay, it's not going to be counted against you. That is the 0 to 1, meaning, okay, all correct answers are scored. Okay, so where does this right minus wrong and 0 by 1 rule happens? In SATA questions, in targeted SATA questions such as this, in matrix Q&As. The one that I will be showing you later would be, I think, the third or fourth question, as well as that on the clinical reasoning, which is also part of the questions that I have prepared for you here. So that is how you score it. Okay. Again, if that is the 1:1 or +1 -1 approach of questioning, it should be correct in all manner of forms. If it's asking you three prioritized items, get those three correctly. Anything you get wrong, taken against you. Then there would also be the 0 by 1, which is essentially scoring you for every correct answer that you got. I would bet you some of your reviewers or some of your live classes weren't able to tell you that. Okay. Because that's how NCLEX is now being adjusted. Okay. I want to emphasize the first quarter of 2025, the passing rate of NCLEX was only 46%. Okay, not even 50%. So if someone is going to tell you, hey, we have a 100% passing rate, that's statistically impossible, because the actual the actual count of the NCSBN itself is not even 50%. By that number alone, you have a 50% chance of passing NCLEX. So how do we increase the chance? Effective knowledge of what you're about to take, continuous practice, which we are doing at the moment, and being aware. Okay, not just the knowledge of the exam, but being aware on how the exam is assessing you. How is it evaluating? Okay, enough of the structure of NCLEX. Let's now go and focus on answering this question. So let's erase everything on the slides again. So, putting it simply, we only need four very important hypoglycemia signs and symptoms. Okay, so let's begin. Would we include shakiness, jitteriness, restlessness? Okay, it is included. Yes, it is. Could we consider polyuria? Mhm. Essentially, no. Okay, why? Because sometimes the body here is what? The body here is on a compensatory mechanism. Hypoglycemia is an indication that the body is starved of nutrients. So essentially, your body will try to keep as many fluids inside. That is why your sympathetic nervous system would prevent you from peeing, would prevent you from having excessive, okay, salivary gland activation. It makes your mouth dry. Okay, the body is stressed at the moment, so polyuria is not included. So how about irritability? Shakiness and irritability, I've already said that. Yes. Okay, because why? This is the sense of impending doom. Remember that your glucose is imperative to the functioning of the brain. So a decrease in glucose would also indicate a decreasing function of the major organs, including the brain. So the patient becomes a little bit more irritable. How about a fruity breath odor? Okay, number four. Would it be included? Mm-hmm. Would it be included? Of course not. Okay, of course not. So this is for your, okay, this is for your what? This is for your DKA. Okay, in fact, together with Kussmaul's respiration, that is your actual, okay, significant sign and symptom. Would there be diaphoresis because of the active jitteriness? Yes, there is also a possibility of diaphoresis. So the last one, would we include confusion as well? Just like what I said to you, glucose is needed by the brain in order to function effectively. So much like oxygen, confusion could also be included. That is also the reason why we are taking as part of the standards of stroke protocol. If a person is actually going to be ruled out in stroke, it is imperative that if the patient would come into the unit, the first set of vital signs should also include a glucose check, because the confusion could be stemming from hypoglycemia, not, okay, not just on the stroke itself. So again, it's 1, 3, 5, and 6. So if you got it correctly, thank you guys. Congratulations. You have done it well. Okay, let's go to the second question. Okay, I prepared this as close to how it is actually being presented in NCLEX. So this is now a drop down multiple choice. Okay, it changed the way that the multiple choice question is being presented so that it would look like a clinical reasoning approach. Unlike in a multiple choice, you are actually using, okay, you are actually using test taking strategies. Could we still use it? Yes, yes, we could. We could still use it. So with this one, okay, I think I've also added this in a question previously. This is now hypokalemia. Okay, so what does hypokalemia does? Hypokalemia creates a problem when it comes to the QT. So there could possibly be a prolonged QT. Okay, there could be cardiac, okay, cardiac arrhythmia. Okay, so if you could look at this, essentially, you could choose cardiac arrhythmia, okay, in the drop down box. So the drop down box, if you remember the picture that I was have the screenshot, I'm not sure if this is working because I'm having some internet issues right now. You could literally see the choices there. It could either be phlebitis, hypotension, cardiac arrhythmia, and hyperreflexia. Okay, hyperreflexia could be for, okay, hypocalcemia. Phlebitis would be a problem for coagulative condition. Hypotension could be more focused on shock. When you're talking about hypokalemia, okay, on this one, this would be cardiac arrhythmia. Okay, so always remember, if that would be the thing, if your potassium went below 3.5 to 5.5, it is best that you anticipate and initially recommend the doctor to give potassium replacements. Okay, you cannot, okay, you cannot just let go of hypokalemia because it would lead to very dangerous cardiac arrhythmias. Okay, going forward, we now have a true or false question in NCLEX, but it is on a matrix. Okay, so this is what you call a matrix multiple choice. Okay, otherwise known simply as a matrix question or a matrix table questions. So, this is a concept as well of clinical reasoning, understanding your ability, okay, or giving the exam a way to understand your ability to think through a given situation. So again, this doesn't need a case. It would just present the question as is. So what would be the main subject of this question? The main subject of this question is albuterol and beclometasone. So of course, albuterol is your alpha adrenergic agents that is sympathomimetic that trigger sympathetic nervous response. So it would open up the airway in order. Remember, when you're in sympathetic nervous response, it is a response of the body when it is being stressed. So it would allow more, okay, more oxygen as well as preservation of whatever nutrients and water you have in your body. Beclometasone, in its case, is a steroid. So these two are essentially a staple medication for your asthma. Now, the question here, particularly the stem, is indicate whether each statement is true or false. So this is how NCLEX is now testing your clinical reasoning. This is where NCLEX, the NGN to be exact, has been transformed to more than just a critical thinking focused questions to something that is focused on your rationalization and your overall reasoning. The highest level, because when you're talking about this in Bloom's taxonomy, this is already at the evaluate area as well as the synthesis area, which is you are creating your own decisions based on what you are analyzing at the moment. So your decisions to what is true or false is based not just on your knowledge, but also on applying it in the actual sense of the condition. Now, what would be the answers for this? Let's begin with albuterol being a rescue inhaler is used during acute asthma attack. Just like what I told you, there would be a closure of your respiratory tract. Okay, so there's a closure of your airway. So what do we need to do? We need to open it. Could albuterol, okay, could albuterol open, okay, the airways? Yes, it opens the airways. Therefore, this is through. Okay, in NCLEX, this is not a chart. This is a radial button choice. Okay, so if you see a checkbox wherein when you click it, there's a check, that is a SATA, meaning it could be one or all. Or just like our question number one, if there is an indicated number of questions or other answers there, you need to meet it effectively for you to be scored effectively as well. In most cases, for this one, since there is an absolute truth in the answer, it would be a radio, or rather a radial button, wherein there's that small circle that when you click, there will be a dot in the middle, especially for those of some of our nurses who are not familiar with the terms. That's why I'm giving you a characterization of it. Okay, beclometasone should be used before albuterol for faster relief. Okay, what does steroids do? Okay, steroids eventually decreases inflammation. So it is imperative that we give this in a way that it will be absorbed. Okay, absorbed by the airways or by the cells in the airways in order to prevent the inflammatory reaction. So is this a true or false statement? This is a false statement. Now the third one, will we rinse our mouth or rinse the mouth after using beclometasone to prevent thrush? Yes, because if there would be, okay, if there would be a decrease in the inflammatory reaction, it would actually create a chance for fungal infection to happen. That's why we needed to have them rinse their mouth with water. Okay, and of course, you could also use a meter dose inhaler in order for you to make sure that these medications are in aerosol mode. That would allow it to be absorbed faster. So, again, it's true, false, true. So, whoever got it correctly, nice job. Nice, nice job. Okay, now let's talk about intracranial pressure. So this is now the classic select all that apply. Okay, so no numbers that are indicating how many you're about to take, just straightforward what would be the interventions that are appropriate for your intracranial pressure. So this is where your 0/1 ruling of scoring will be applied. Every answer that you will get correctly will be given a point. So let's go into it. Okay, let's begin. Keep the head of the bed at 30 degrees. Could we need to make sure that the head part of the bed is elevated? Yes. Why? Because this actually relieves pressure. That is why, especially for people with stroke, it is imperative that we need to put the head of the bed 30 degrees. Do we need to do suction as frequent as we could? Okay. Just like what I said before in my previous videos, do not question the question. Okay. Do not overthink the NCLEX question. If your concept is ICP and your STEM is focused on intervention, just focus on it. Interventions for your intracranial pressure. Nothing more, nothing less. Suctioning would help if there would be cough, but there's no indication of cough there. So two is incorrect. Maintain a neutral head position, meaning a straight head position? Yes. Okay, so you will also add this. For all we know, the ICP could be a subdural hemorrhage or an intracranial hemorrhage or a mass that is slowly building up in the brain. So if you will place or if you will favor your head or the patient's head on a certain angle, it could change or shift the pressure. And the next thing you know, there will be a midline shift of the brain herniation could happen, patient could die. And it is quick, guys. It is quick. I am a neuro nurse for a good 2 years now, and one thing that I could tell you when brain herniation happens, it's the end of the line. I encountered one patient who I was talking to at 9 in the evening, giving her 9 p.m. meds, and the next thing I know, by 12, she gave her last breath. We didn't activate a code. Thankfully, she was DNR DNI, accepting the fact that she has at least a 10 millimeter mass on the middle of her brain. Went into the CT scan, and lo and behold, brain herniation. The brainstem was already compressed because the actual, okay, the actual mass is also continually bleeding. It's a bleeding mass. That's how quick. I was talking with her. She was giving me her points of views. We are having a very good conversation at 9. The next thing I know, she's gone. That is how quickly it is. So be very, very mindful, particularly of the positioning of the head. Now, encourage coughing. Coughing adds. Okay? So it adds pressure. That's why if you will have patients who will have ICP problems, you could also expect that they will have medications that will stop them from coughing. So Tesalon or benzonatate is one. Cough drops. You could also, if that would be a dry cough, dextromethorphan. Okay, so you're not going to include this. And finally, monitor for the changes in the level of consciousness. Yes. Any form of changes in the consciousness could result or could be an indication of a deteriorating brain injury or a brain condition. So, everyone who answered 135, give yourself a round of applause. Very, very good. Now, moving to the next question. The next question is a clinical reasoning question. So, how does NCLEX, okay, how does NCLEX score clinical reasoning? You need to complete it in its most effective and correct form for it to be scored. This is one of the hardest questions simply because both answers weigh in on its correctness. So if you choose one, the entire question would be tagged as wrong. Let me repeat it. If you choose one wrong answer to this two, okay, to these two drop down boxes, this would automatically be counted as wrong because the reasoning is incorrect. Okay, so how do we answer questions like this? The best tip that I could give you is to still apply, which is the subject. The subject of this one is warfarin and 5.5. We all know that this is already an abnormal INR. So if it's an abnormal INR, there's a possibility of bleeding. And in most cases, the treatment will then be, if you were able to look into this, you have three options: that was held, increase in dose, or decrease in dose. Do we increase the dose of warfarin? Yes, it could be titrated, meaning it could increase or decrease depending on the patient's INR. This is very much common, especially for people who have hypercoagulative conditions. So let's say, for example, people who have DVT, as well as that of a person who is receiving this together with Eliquis, especially if they would have AFib. So you needed to make sure that you are aware. And does this happen in home care? Yes. I could vouch for it. Being a home care nurse as well on the side for about 1, 2 years, I agree. I've encountered a lot of people whom I need to do an INR on the spot test on their living room in order for me to tell the actual warfarin clinic of their status so that we could adjust the dose. So, with this at hand, it is an abnormal INR with a risk of bleeding. Technically, the treatment will be held. Now, the next question: what would be the thing that we are going to do? Okay, you have three options here: give protamine sulfate, start with vitamin K, or start a platelet transfusion. Now, the reasoning is common sense as well. The situation indicates that you are a home care nurse. Would there be a possibility that you could have an access to a platelet? Of course not, right? There's a possibility that you could not have access to a platelet. And infusion, okay, as a whole, may it be platelet aggregates, pure red blood cells, you need to be admitted. Why? Because it would need continuous monitoring. It would need continuous nursing intervention and evaluation because your blood products, regardless of what it is, could actually trigger hypersensitive reactions, anaphylactic reactions. So, could we consider starting a platelet transfusion as a good answer? No, take it out. Now, this is warfarin. The best way to actually start, and in most cases, they would also have this as part of their treatment, okay, as well as that of their medication, is to start vitamin K. Or you could order as a home care nurse, you could trigger an order by calling the provider of the patient and give an immediate order for a vitamin K based on the INR. Sometimes, anyone who's taking warfarin here in New Mexico, I'm basing it on the policy that I have encountered, they're connected into a warfarin or an INR clinic. And immediately there are, for safety precautions, much like people who are receiving opiates, they have naloxone together in their prescription. The same goes with warfarin. They would also have a vitamin K prescription in the ready, just in case to prevent any form of bleeding tendencies. So again, the answer is held and then start with vitamin K. Okay. So make sure as well, just an additional one, when you're talking about hematological disorders such as bleeding disorder, give the teachings that are necessary. Make sure that there is no clutter on the floor. Make sure that the person is walking with either a cane or a walker, especially if there are mobility problems. Make sure that the bed is in the lowest position to prevent any form of fall, because again, with bleeding tendencies, it would only take one fall. And everything could go into the worst case scenario. Could be a brain bleed if they hit their head. It could be a bleeding hip fracture if they would bump their bottom on the floor in a very heavy manner. So that is your clinical reasoning question. That is how you answer it. Okay. Now, the next one we have is your classic drag and drop. Okay, drag and drop. Drag and drop is fairly simple. For those who are about to take the NCLEX, what you see now are the alternative form of questioning. So you see how we run our discussion? We began first with the basic questions so that you could get aware, and then we put analysis question based on the situations that are presented to you so that you could practice your analyzing skills, and now we apply it. Okay, this is how you should approach NCLEX. You don't go at it and studying the entire nursing discipline again. Okay, I am telling you guys, it took you 4, 5, sometimes 6 years, depending if you're working, in order for you to absorb all of those nursing knowledge, and you're going to be tested only for 5 hours. So, I have nothing against 40-day, 90-day program. But if you're going to look at those best practices out there, boot camp, Archer, you will see how concise, even New World, how concise the review is. I'm not saying that any review centers or review programs or every one of them is weak or it's not good, it's not beneficial enough. Do what you want to do in order to, of course, reinforce your concept, but be smart about it. Okay? Because again, sometimes even if you know the concept, but if you don't know how to answer these questions in front of you, then that's another problem. Okay, so what is a drag and drop question? A classic drag and drop question, as you could see here, is actually you putting this into order. So in the actual NCLEX exam, you could click. Oh, I already gave the answer. You could click, okay, an item. Let's say, for example, the first one, measure the length from the nose to the ear to the xiphoid, and then you could move it according to where it is supposed to be in the process flow. Will it be the first, the second, the third, and the fourth? It will not light up green, just like the one that you were able to see a while ago. It will not light up green because it will not give you the correct answer. You need to click submit at the bottom in order for you to actually be able, okay, to go to the next answer, and it will not show you the answer. Okay, that's another thing. That's why I keep on telling people, if there would be someone that would tell you that they have the copy of the examination including the correct answers to it, and then they would, yes, I in the next post that I will actually show you a case in one of the groups that I am a moderator with, that they got scammed. Like seriously, guys, $400 for a set of U-World questions that they are parading as NCLEX questions. So be careful, okay? Be careful. I just want to segue that because a lot of people will be saying they have the correct answers for this. Because again, NCLEX doesn't give you the chance to go back. It's not like Prometric. I'm not even sure if HOD is still doing it. HOD before you could literally get back to another item to review your answer before you actually click yes and finish the exam. In NCLEX, no. You click next, it's the end of the road. That's why it's impossible to actually create an cheat list or a leak item set of this one. Okay, now we had it out of the way. How do we arrange this in the best possible manner or in the correct process flow of starting, okay, an NGT? So, do we usually do NGT for people who will have bowel obstruction? Yes, okay, because we don't want excessive, okay, we don't want excessive pressure from building up. And if the patient have just eaten, that could actually push more pressure on the obstructed area. And the next thing you know, there would be necrosis primarily on that region. Deadly? Yes. So, what is the best answer? I already was able to show it to you. Arranging it effectively would end you up with this. So, first, measure the length from the nose to the ear to the xiphoid process. In most cases, that could be at least 65 to 75 centimeters, depending, okay, depending on how tall the patient is. So, how do we know it's 65 to 75? Because the actual NGT tube has a calibrated measurement there. Next, we are going to lubricate the tube. Anything that you place on anyone's orifices, mouth, urethral orifice, anal orifice, make sure that you lubricate it. Okay, so that is not a pleasant feeling. Okay, it's never a pleasant feeling. Insert the tube into the nostril. So, what are the things that we need to consider here? Okay, make sure that the nostril doesn't have any form of bleeding. Make sure that there is no deviated septum. So, what is a deviated septum? Okay, in the middle of your nose, this one, there is a septum in the middle of it. So make sure that you visualize first that the septum is actually clear before you insert it, because that could put unnecessary pressure, resulting to again clogging of your NGT, resulting to removing it and doing this again with the patient. Believe me, guys, this is torture. This is not the one that you would want to feel, together with Foley, of course. Then, after lubricating and inserting it into the nostril, have the client tilt the head forward and allow herself to swallow. Why? Because if you have it like this, what would happen is it could actually loop at the back of your postnasal region and then go out of the mouth. And again, we're going to remove the entire thing. Okay, flush it and clean it, lubricate it, and then place it again in your patient. Another form of torturous maneuver. Very, very painful. So, with you allowing your patient to tilt the head forward and, okay, allowing them to swallow naturally, could allow your postnasal area to actually be open all the way to the pharynx. And that would allow it to enter flawlessly in your esophagus, because the thing that you don't want to happen is that if this is also open like this, it will go to the trachea, because the trachea will anatomically be in front. But if you're going to tilt forward, it would actually open up the esophagus, more likely to be aligned in your oropharynx in this region. Then allow the client to, okay, slowly but surely swallow, and that would allow it to push it down. Then secure the placement either with a tape. What we're using as well sometimes is a bridle. So, what is a bridle? Okay, the bridle is the best that I could recommend in securing it. So, the bridle is essentially a small thread that is connected at the back of the nasal septum. Okay, so that cartilage of the nasal septum is strong enough to anchor it. So I'll bring one. I'll bring one in the next video that I will have. I don't have the bridle right now, but I do have it in the unit. I'll try to bring one to give you guys a sample. So usually we place it in order to prevent the tape. Why? Sometimes tape could trigger allergic reaction. And the next thing you know, the patient will have redness in the area. The redness will be a little bit inflamed, and now you will have macerations associated with it, which is adhesive based pressure injuries that could be developing in the nose. And you don't want that to happen because that could create a necrotic nose. The last thing that you don't want is that you place an NGT with your patient ending up without a nose. So please make sure make sure that you prioritize your patient's long-term safety as well, because safety doesn't just start at the beginning of the intervention. It could be lasting. And finally, okay, verify the placement through an X-ray. Okay? Verify it through an X-ray. X-ray is your most dependent one. But initially, what you could do would be what? What you could do is the actual introduction of air with proper auscultation here, okay, below the xiphoid process in the epigastric region. And there should be a gurgling sound. But if you're talking about the NCLEX in the perspective of safety, X ray, portable bed X ray is your best. Okay? Anterior posterior lateral AP view of the abdomen is the advisable one. Okay, moving forward, let's talk about your. Oh, what happened there? It jumped. Okay, so you now have a patient. So this is now an analysis with your prioritization. So sometimes, in order for NCLEX to make it okay more challenging, especially if you're answering it progressively, is that it will throw you a progressing condition. So what does a progressing condition type of question is? So a progressing condition question like this would indicate a base condition, which is eclampsia, and then you have given an intervention. Now, there could be complications. So there is a progression of the condition for even may it be a positive one or a negative one. This is a negative. So this is an actual complication, the progression towards a complication. So which of the following is a complication? Putting it simply, if you're going to look at it, patellar reflexes of 2 plus, is it good? It is good. Respiratory rate of 10, okay, this is your main concern. Why? Because urinary output of 45 ml per hour. Normal? Normal. Yes. We are what? We are 30. Okay, most books will say 30 ml per hour is your normal urine output. Okay, and that blood pressure of 140 over 90. Pre-eclampsia. Essentially, this is increased BP. So increased BP is could this be considered? Yes, it could be considered normal and expected. So if you have a respiratory rate of 10, this is essentially respiratory depression. That will eventually lead to respiratory arrest. So what would be the medication that we're going to give? Since this is already what? Is this part of eclampsia? No, this is part of magnesium toxicity. And what would be the antidote for this? Antidote would be your Calcium gluconate. Okay. So this is the one that we're going to give next. So sometimes NCLEX is going to give you this as part of a case study when it comes to preeclampsia. And then the next thing you know, there will be something about calcium gluconate. Okay, that's why a lot of people are also saying it's a little bit easier with the case studies because the case study is essentially showing you everything. There could be a note there that is a progression of what happened to the patient, including what have they done. And now you will have an idea of how are you going to act. This, though, are standalone question. That's why you need to build your analysis because, again, you will only have, okay, 18 questions associated with your case study. So essentially, all the other questions that you have, let's just say you're going to be at a maximum of 150 minus 16 or minus 18. That is a total of 132 questions. 132 questions standalone. Half of them could be like this. That's why you need to build analysis. That's why you need to build that format of thinking that every form of information can be an actual cue or evidence that will help you decide. That is what NCLEX about. It's not about mnemonics. It's not about reading every available book in the market from Brunner and Sudart, Ignatavicius, Vidivek, Wong, Pilitary, you name it. I myself have read it being a book reviewer, particularly from some schools back in the Philippines when I was in the academy there. But up until now, it's not retaining here. That's the reality of it. That's the reality of it because it could be clouded with experience, stress. For all you know, everything that I'm seeing here right now, that's why I'm doing this on video because it's easier to be retained because you could always get back here. Because if I'm going to give you a written answer like this, just a written post on Facebook, believe me, I could bet I could bet $100 read it, you cannot remember it after 24 hours. It will be another set of information. So this is the best way that I could connect with you. Again, three important things. Build your analysis skill, understand where to get all of your information and evidence, and make sure that every answer counts. That is how you pass NCLEX. Now, moving forward, okay. Another clinical reasoning question. Identify what is expected versus unexpected in the findings of right-sided heart failure. So essentially, when you're talking about right-sided heart failure, the problem is there is a buildup. Okay? There is a buildup on the right side of the heart resulting to backwards failure, essentially putting the blood back to the circulation. So, if there is no capacity, okay, for the blood to move into the heart, what are you going to expect? Okay, so what is it that you are going to expect? You need to expect what? You need to expect, oh, what happened there? Okay, you need to expect that there will be systemic edema. Okay, edema or buildup of water away from the central area of circulation, which is the lungs and the heart. That's why in your left-sided heart failure, it's just congestion of the lungs that would eventually lead to pleural effusion. Now, on this one, what would be the best thing to expect? Let's begin. Just like what I told you, the blood is not going into the heart. So again, blood, okay, is not being pumped, okay, away from the heart. So essentially, blood and water flows back. to your body. So, could we expect peripheral edema? Yes, it is expected. Could we expected or could we expect crackles in in the lungs? Just like what I told you, it could not reach the central area of circulation, which is the heart, as well as that of the lungs. So this is unexpected. How about jugular vein distension? There's too much pressure of water trying to get into the heart. Jugular vein would increase? Yes. Why? Because the vein is also the main blood vessel, important for it to actually bring the blood to the heart. So this is expected. How about hepatomegaly? There will be excessive pressure, and because it's reverted back to the portal vein towards your towards your liver, will it build it up? Yes. Hepatomegaly is also expected, to the point that sometimes ascites could happen. Anasarca is a possibility, or pathologic edema all over the body. So whoever was able to get this, job well done. So how do we answer this, and how is this being scored? Okay. There is a possibility that if this is, let's say for example, as specific as right-sided heart failure, it is expected and it will be expected that you know it. So this is a right minus wrong. Okay, in most cases, it's a right minus wrong. So if you got here one wrong, it will be counted against every correct answer that you will have. And then again, based on the logit statistic principle as well as the evaluation of capacity, it would adjust the difficulty as well as your trend in answering. Okay, last question. Oh, not yet last. Second to the last question. You now have a patient who is receiving oxygen via nasal cannula at 4 liters. This patient, though, has COPD. So when your patient has COPD, what is it that we're very much afraid of? Oh, what happened there? Okay. What is it that we're very much afraid of? We're very much afraid that what? In COPD, the problem is you could not have an effective circulation. So any form of air that you are going to get is essentially going to be stuck inside your lungs because of the poor circulation, or the actual ventilation, not circulation, but the ventilation of air in your lungs. So, placing this condition, so if you administer oxygen at 4 liter, this places the client at risk for, this is again a clinical reasoning question, but multiple choice is applied. So if you will put too much oxygen, it will what? Is it oxygen toxicity? A lot of you are actually saying oxygen toxicity. It is essentially, okay? What do you think? Mm-hmm. What do you think? Did you answer correctly? Someone who will be watching this will answer it correctly. I was saying oxygen toxicity. No, it's not. It is going to be hypercapnia. Yes, it is hypercapnia. Why? Because even though you have oxygen, what's going to happen? Oxygen will bind where? Will bind with hemoglobin. It will still bind with hemoglobin, even with acute or rather with chronic bronchitis. So what happens here? Okay, too much O2, particularly in COPD, will reduce your hypoxic drive. Eventually, that hypoxic drive, the one that's telling your brain that we need oxygen, would essentially go down. Now, of course, what happens to oxygen? It is being absorbed by the body. because it binds with your hemoglobin, and your hemoglobin is essentially running around your body through your red blood cells and then giving it off with your what? With your cells, with your tissues. In exchange for what? Carbon dioxide. Unfortunately, carbon dioxide is a waste. And the only way for you to remove it is what? The only way for you to remove it is breathe. Expiration. You need to exhale it. That's the only way for you to release it in your body. Unfortunately, it's not going to happen because your airway is blocked. So apart from the fact that you have hypoxic drive, which is essentially that will tell your brain, hey, we already have enough oxygen, stop breathing. The next thing you know, carbon dioxide will also build up, respiratory acidosis happen, CO2 retention. That's why it's a little bit, oh, because there's like oxygen here. There's automatically oxygen toxicity. Okay, it's not going to be oxygen toxicity. It will be hypercapnia because that is the one that will deteriorate the functionality. Okay, it will deteriorate the functionality of your of your lungs when it comes to exhalation and inhalation. Okay, so hopefully that was able to clarify your queries. Okay, most of you answered oxygen toxicity. Okay, we'll have more discussion of that in the moment that we're going to focus on your when we're going to focus on your respiratory system. Last question of the day, okay, or the night, wherever you are in the world. Which medication should be held prior to a scheduled CT scan with contrast? Okay, this is a select all that apply. I'm very sorry, guys, if I wasn't able to place the select all that apply instruction. So to keep it straight, first one is metformin. Okay, because metformin could create lactic acidosis. Essentially, with this pushing your body to actually maximize, okay, the synthesis of your glucose, it could create increase in lactic acid. Then another one would be your ACE inhibitor. So which is a ACE inhibitor here? Lisinopril. And last one would be a diuretic. Why? Because both of these are kidney, okay, concerns. And where does your contrast go in order for it to actually be removed from the body? It goes to the kidney. Okay, so if you will have too much of your ACE inhibitors and diuretics, it will deteriorate the functionality and the physiological capacity of the kidney, resulting to the buildup of contrast, which could actually create acute kidney injuries. Okay. So, how was your score? Was it 10 out of 10? Okay, a lot of people say oxygen toxicity. We'll discuss more of that because I was looking at the time and oh, wait a minute, it's 1 hour 36 minutes. Okay, so I'm just going to leave you with one final coaching thought, especially for those who are about to start their journey in preparing for NCLEX. Again, guys, always remember, as you can see here, the best way for you to start is to accept that there is a heavy load ahead. Whatever, okay, whatever it is that you're going to face in life is going to be a heavy load ahead. A lot of things would happen. Starting a family, it would entail budgeting, understanding child rearing, all of those stuff. So, what do we need to do? Control and prevent anything that we can. All controllable things that could limit the load and build from there. Because sometimes we just need to let go of some unnecessary things in order to clear our mind and accept more to face the troubles ahead. Thank you very much, guys, for staying with me for more than an hour this time. So, watch out. We will have a discussion with pharmacology. That's the most requested. That's the most requested concept that we're going to discuss. So, rest assured, guys, that I will be with you with that. I'll be happy to make sure that you are going to. Let me just get out of the share screen and go here. Okay. So, stay tuned with the group. Make sure that everything is a-okay for everyone in order for us to maximize our activities moving forward. So watch out, okay, guys, watch out for discussions focusing on pharmacology, psychiatric nursing, and one also the most dreaded question and answer, prioritization and delegation. And as a gift for our 400 followers right now, I'll give you 30 items of prioritization and delegation questions that you could practice on an online platform coming from yours truly. Again, free of charge. Thank you guys for staying with me again. Stay tuned for all the questions and more concepts, contents that will be helpful in your NCLEX preparation. Have a good day, guys. Be the best version of yourself out there.